All right, welcome everybody to Emerging Technology Sub-Work Group Call. We have a very special guest with us, Denny Brennan from Massachusetts Health Data Consortium, or MHDC. I've had pleasure working with Denny on the WEDI board on the Education Committee. But what I've been most impressed with, Denny, is your Massachusetts community and community between payers and health plans and participating vendors. And whenever it comes to making some of these initiatives successful, particularly like prior authorization, you need trust and you need people to buy in to be able to participate and be able to have trust and be able to exchange information and to be able to make sure that the responses are true of heart, if you will. So it's been interesting hearing how Massachusetts has done a number of initiatives through the years in advancing technology. I know part of what we'll be talking about today is those relationships. Also in your experiences with starting off with the prior authorization FHIR CRD, where you're asking whether acknowledgement is needed or not. And we'll also talk a bit about artificial intelligence and what's happening in your community there. So, Denny, as the CEO of MHDC, you're on stage. Thank you so much.
Well, thank you, Ed. Thank you, Sam, and my colleagues from WEDI and everyone who has joined us today. The title of this discussion is Advancing Prior Authorization Automation, but that really kind of understates what it is we're trying to do or where we hope this takes us. But we wanted to focus on prior authorization automation because it's a very useful lens for looking at the impact of emerging technologies on healthcare treatment, payment, and operations between providers, health plans, and ultimately consumers. So very briefly, I'll tell you a little bit about who we are. And I mean very briefly, but thank you, Ed, for that introduction. We've been around MHDC for 45 years. Our single biggest asset, we're a small company, not for profit, but our single biggest asset is the goodwill that we've engendered in the health data community in Massachusetts over that time. Most of our members include most all of the health plans, a substantial majority of the healthcare providers, both ONC, CMS, and Massachusetts Executive Office of Health and Human Services, as well as our Medicaid agency, Mass Health. We have the associations that span both the provider and the payer side, as well as now increasingly consumer or patient advocate associations. We have individuals, we have technology vendors. We're all united with by a common interest, a shared interest in how can we build a much better health system where data enables consumers to make the best choices, to secure the healthcare they need when they need it, and do so with a kind of visibility that you would expect in open markets, where you would expect in your purchase of consumer goods, your purchase of financial. I'm at a conference today. Everybody is talking about value-based care. But the reality is, until you have an open market, value-based care is difficult to do. So we're pushing toward that. We're organized across 4 major service areas, if you will. Data governance, what are the data? For what purposes will they be used? How do we achieve consensus among different stakeholders in the use of data? What are data mapping, data quality, data-related regulations? We also have a health information exchange called NEHEN, or the New England Healthcare Exchange Network. NEHEN is now moving from being an EDI network to being an EDI plus FHIR exchange. So we will support both the exchange of administrative and clinical data and begin to lay the groundwork for automation. We also provide analytics and reporting for a number of our members. through a web-based tool. And we do consulting services for organizations that want to go that much further in what they want to do with respect to health data. Those services rest on a collaborative community. We are a membership organization, but we've placed a particular emphasis on value-added services where our unique position in the market, our goodwill, the fact that some of us have been around for a long enough time to know people in the room and to have developed a degree of trust with each other, to do things that are very difficult to do if you're a corporate player or a participant in the market. But if you're a distance removed as we are, and you're neutral with respect to which sides of the exchange, which participants are involved, we are not aligned with any of them. We maintain a neutral and objective stance. So that's enough about us. I do want to talk a little bit about the journey we've taken over the course of the last 6 or 7 years. We have been working on health information exchange between payers and providers for a long time. We founded NEHIN in 1997. We spun it out as a separate freestanding company, and we brought it back into MHDC just a couple of years ago. But we've been actively involved in information exchange between payers and providers over the course of that time. We even worked with NEHIN in 2017 to do one of the first automated prior authorization pilots. And this was pre-standards. This was, does automation work? Can we do it on a one-to-one basis? And I'll tell you a little bit about that shortly. Then in 2022, we introduced FHIR into a prior authorization prototype that we implemented with a major payer and a provider organization and a technology vendor here in Massachusetts. Thirdly, we built in partnership with an organization called the Network for Excellence in Health Innovation, we undertook a statewide prior authorization awareness building, surveying effort to understand what the community considered to be the most valuable changes to prior auth that could be implemented and ultimately could be legislated by the state, which is a very important aspect of our work, is that we've been working with regulators and the state's agencies to make, standards-based open prior authorization automation the law of the Commonwealth. We have a ways to go, but we're making good progress on that. Fourthly, we've undertaken to expand, as I mentioned earlier, the scope of NEHIN to be a bidirectional, payer-provider agnostic interoperability engine for exchange and automation. So we're combining FHIR and EDI. We're looking at both, the operating rules as well as the implementation guides that come out of the Da Vinci project, for example, to build a robust robust engine for the exchange of data and for the automation of that exchange, so that we can do what we're uniquely good at. And I'll tell you a little bit more about that in a while. And lastly, I'm going to spend some time talking about AI. And while it's focused on prior auth, it's the lessons we're seeing or the learnings we're gathering about AI are probably pretty broadly applicable. So that's kind of the lay of the land for our discussion. And I'll try to get us done with 30 minutes for us to talk, so I'm not using up more airtime than I should. Our first effort in prior authorization back in 2017 involved our exchange organization, NEHIN, as well as a number of health systems and payers. We had Point 32 Health, which at the time was Harvard Pilgrim Healthcare. We had Bay State, which is the largest provider in central Massachusetts, Partners Healthcare, now Mass General Brigham, UMass Memorial Health Alliance, VNA, and the BIDMC's OBGYN service. And what we did was we set up an automated prior authorization exchange using technology from a company called Informatics in Context, which I believe is now a Cognizant organization. And what we focused on was automating the availability of medical guidelines and policies. We provided questionnaires instead of faxes through a shared portal. And we discovered, at automating this kind of exchange reduced the number of manual interventions by about 82%. So we found that we had touchless prior auth happening in 82% of the transactions. This was a huge, huge change. And it gets at what we're talking about today when we say, when providers find out what actually requires a prior auth, it's far less often than what they expect. You know, between 50 and 80% of prior authorization submissions are unnecessary, but providers don't know. And they've had experiences that have created some mistrust in the system. So they overcompensate, and it's understandable that they do. We saw response times move from days to minutes. And we found that we could update guidelines as the system evolved, and do so in a matter of, you know, a day as opposed to days or weeks. So this had a really outstanding impact. But we also discovered some things that I'm sure are pretty self-evident to us today, which was we don't have any standards. We can't expect payers and providers to adopt a prior authorization methodology that they can't use with all their trading partners. And there weren't the standards at the time for doing this. It was highly proprietary. We didn't have a consistent technical infrastructure, a way of exchanging information, for example, that would allow providers to operate within their electronic medical record rather than going to a separate portal. We also found that, you know, adoption and accommodation to new standards and new expectations was harder to do. We didn't have the kind of scalability that comes when you build on both data standards and technical exchange standards. So we recognize that while it was a terrific experiment, we learned a tremendous amount about how this works and the kind of the orders of magnitude improvement in efficiency and effectiveness, that it wasn't scalable. We would have a very difficult time expecting payers and providers to use a separate technology outside of their systems of record that will require as much work to scale as this did. But we walked away from it with a sense that this was a very successful project. I'm going to stop there. And if anyone has a question, please interrupt me or raise your hand, or Ed, tell me if I should take a pause or breath and take any questions from anybody. But I want to be sure that I'm giving people time.
Yeah, take one deep breath and we're ready for the next slide.
Thank you. All right, I won't get into this too much because we're going to be talking about this at the November conference. But our second effort in prior auth was focused on a standards-based implementation, where we worked with Blue Cross Blue Shield of Massachusetts, the New England Baptist Hospital, which is a specialty orthopedic hospital, and its technology services vendor, Olive, which is now a part of Availity, or at least the payer portion of Olive is now part of Availity. And what we did was we did use an HL7 FHIR coverage requirements discovery implementation guide, and with funding from our colleagues at the Mass eHealth Collaborative, formerly under the leadership of Mickey Tripathi, we received a grant to pursue this study. And after about 6 months, we saw results that were consistent with what we saw in the former prototype that I just reviewed with you, where we saw the amount of prior authorization submitted drop by 50%. Now, this is for orthopedic care, which is intensively prior auth laden. Prior auth is required for a lot of these patients, whether it's admission to a hospital for a total joint replacement or any kind of musculoskeletal procedure, there's likely to be prior auth. So even in a fairly prior auth intensive environment, we found the number of prior auths that were unnecessary and reduced the number of submissions by about 50%. So you'll learn more about that at the conference in November. We'll be excited to have my colleagues, Dave Delano, and our friends from the Network for Excellence in Health Innovation, Wendy Waring and Lauren Beadle. They'll share with you more details about that project. But that was a very interesting and an exciting opportunity for us to start playing in the standards sandbox. Next, and almost simultaneous with that, we worked with NEHI to convene what we called TAG, or the Automation Advisory Group, which was about payers, providers, technology companies, electronic medical record vendors, state and federal government representatives, subject matter experts. And we sat down with them, and funded by the Massachusetts Health Policy Commission, which is the government agency responsible for cost control of healthcare in Massachusetts, which is a daunting and as yet largely unsuccessful effort. Though I have to admit the Policy Commission has done tremendous amount of work. They have very strong leadership and very good commissioners, but we live in a state where healthcare is very expensive, and reining in those costs is difficult. But they were keen to look at how prior authorization automation would not only reduce costs, but also reduce burden, especially for patients and caregivers. So with funding from them and from 4 technology companies, Change Healthcare, Cohere, Hook, and Z Omega, we undertook a pretty comprehensive survey and evaluation process with the Automation Advisory Group so that we could really both educate them and get their perspectives on what would really work in prior auth. And interestingly enough, after everybody listened to everybody else, everybody gave their own point of view, the one change that rose to the top of the list was automation. We thought gold carding or policy changes or other more structural changes would be what people would recommend. And some people did recommend those. But other people were very compelling in saying, well, that may not work for us. You know, gold carding is fine, but if I'm gold carded as a provider with one health plan, how does that help me with my other health plans? You know, there's a lot of complexity in some of these proposed changes to prior auth. But the one thing that rose unanimously to the top was automation. And we came out of our work with TAG with a report called Advancing PA Automation Across Massachusetts. You can find it on our website or on the NEHI website, where we recommended that the automation of prior authorization should be a state mandate, and it should be applicable to both public and commercial payers, with state oversight in a single agency. We strongly advocated for, and we continue to advocate for, the HL7 Da Vinci AGs, or IGs, I should say. That is the implementation guides for prior auth, coverage requirements, discovery, documentation, templates and rules, and prior authorization support, because they are the gold standard for using API technology, data standards, to advance interoperability and automation, more than interoperability, going that next step to automating a process. We also recommended that the state provide funding for organizations who would otherwise be strapped to do this, to support them. I'm thinking the small to medium health plans, providers. The law needs to apply to all providers and all health plans. So there's going to be a lot of organizations that lack the technical, financial, or just expertise to do this on their own without some help. So we propose technical assistance provided through one or a number of technical assistance centers, much as we put in place for the implementation of the electronic medical record. And then we did say there are ongoing improvements to prior auth that should be evaluated and implemented. And with the TAG, we have the beginnings of a multi-stakeholder task force, so we can look at these things and come up with an informed multi-stakeholder opinion and recommendations. But let's get automation done and take some of the noise out of the system. So that's what we came out with that. I'm taking another deep breath now. Now I'm going to talk a little bit about NEHN 3.0. MHDC released an RFP for NEHN 3.0 about a week ago. And what that RFP basically is asking members of the vendor community to assist us with is we want to update our existing EDI services to offer the best overall value. EDI is a very robust, but also a very well-established, standardized technology. We would like to be able to offer more value at the EDI level, but we also want to incorporate fire support and the related infrastructure components that go with FHIR, such as identity management, endpoint routing, security provenance, and a host of other aspects and support infrastructure that is necessary for FHIR to operate effectively. And we also want to be able to convert between X12 and transactions where you need to have a HIPAA mandated X12 exchange. And that's the case with, the implementation guide for prior authorization support, where the financial transaction at the end of the prior auth has to be rendered in an X12 HIPAA compliant standard. We also want to automate, and this is where we go beyond just exchanging data. We want to automate the process. This is where, exchanging data is necessary but insufficient to really making enormous changes in efficiency and cost effectiveness and quality. If we don't automate the process and improve the quality and the efficiency with which these transactions are conducted, we won't achieve the kind of results that we saw in some of the earlier work that we did. So we focused on automating 2 use cases in the NEHN 3.0 RFP. One is prior auth, as we've been talking about, and the other is quality measures exchange, which is complementary to prior auth in that it uses the same technologies and much of the same data, but it's also an entirely different use case with a number of other important benefits that a robust and automated exchange can provide, such as real-time quality reporting, which right now is impossible to do. NCQA is implementing colorectal cancer screening using digital quality measures in 2024-25. No one in the community is ready to do that. And we want to be ahead of that and enabling our payers and providers to start transacting with respect to quality measures in real time as part of this work. And lastly, we want to provide additional support services where if an organization comes to us and says, I'm a health plan, I would really, while I'm working on, building out my infrastructure, getting my back-end systems of record connected to my front-end FHIR services, maybe MHDC, you could take the portfolio of prior authorizations or services where prior authorization isn't required and just let people who submit prior auths for those services know directly on our behalf. We'd like to delegate that to you. There's a number of opportunities to do that. We are looking at it being an invaluable way for health plans to start delivering value around prior auth while they have to do a tremendous amount of infrastructure work in their own black box and within the 4 walls of their organization. So we may well provide these services directly for organizations that want to use us to do that. And again, moving further and further up the value chain from beyond just exchanging information to automating it, and in some cases, doing parts of it for participants directly rather than having the transaction go from end to end throughout. Lastly, I'll tell you a little bit about what NEHN 3.0 is focused on. We've stressed business relationship requirements in our RFP. We want to work with organizations that want to partner with us over the long term. And that means investment in the technology and in the service. It means working with us to co-market, co-evangelize, and build our presence in the region to support this kind of automation and this kind of exchange. So we place a considerable emphasis in the RFP on, partnerships, real partnerships where there's, joint incentives, there's a shared revenue model, there's opportunities for organizations to do well by doing this right and for us to do it together. We've stressed heavily the overarching technical and operational requirements, which are considerable, as are the specific infrastructure requirements for the solution. We talk about vendor orchestration because we know that this is going to take multiple vendors. We don't know how many, 2, 3, we don't know, but we doubt seriously that one vendor will be positioned to do this in its entirety. And we look at vendors that can bring a portfolio of solutions to us that involve other technologies and other vendors as being a model necessary for the successful implementation of that. And lastly, we look at graphical user interface requirements. We need to have a portal to manage this, an administrative portal, but we also need to provide portal access for providers who don't have compliant electronic medical records or don't have an EMR at all. And I'm thinking about, psychologists, psychiatrists, practitioners in solo practice who are professionals who have traditionally submitted their claims the old-fashioned way or sought prior authorization the old-fashioned way. And we want to, stay. Lastly, I'm going to spend a very little bit of time, and I'm staying to my on the half-hour time frame, talking about, sort of artificial intelligence and where we see AI fitting into this. Right now, we think AI is probably most effective in helping providers use their electronic medical records to review historical data and understand historical practice deviations that might result in a prior auth requirement and working to fix that. And a number of the EMR vendors are building that. We also see artificial intelligence playing an important role in making sure data that exists in the EMR in places where it's hard to retrieve, like in free text notes, and having those data populate discrete fields so that there can be that field-to-field, highly granular interoperability that's necessary for prior authorization. On the health plan side, we see AI being used to start to bring policies, medical necessity criteria, guidelines, and evidence-based approaches to care from the back of the enterprise where they reside on multiple systems and bringing them to the front where they're available for review and support for the prior auth process. This is an enormous undertaking for health plans, is to take data that is in systems, some of which are 50, 60 years old, and find a way to bring them into repositories and FHIR gateways that make them accessible to their trading partners. That's a huge undertaking, and AI can help with that. It can help, review all the evidence that exists in policies, medical necessity criteria, and the like, and help health plans identify which of those are most relevant to the prior auth process. And they can also start to understand where, prior auth has been more prevalent among providers, among particular services, so that they can get better at understanding why this is an area where the community is consistently bumping up against prior auth and how to make those changes more apparent to their provider networks. What we do not see is a lot of the hype that is prevalent in conversations about artificial intelligence. This whole idea that the prior auth process can be fully automated with artificial intelligence is a bridge too far. We have enough challenge in front of us to do the equivalent of a robotic process automation, dumb smarts as opposed to smart smarts. And vendors who are selling the full automation of the prior authorization process are selling something that isn't real and isn't going to be real for a while. The idea that you can implement AI solutions directly and seamlessly is not real. There is an enormous challenge to move AI systems into the workflows of both payers and providers, not just in the technology, but just in the way people do work. So the challenges posed by integration are far greater than the vendors who are promising this kind of seamless utility or utilization of AI. It's a big deal. It's got a ways to go. And lastly, there's some major regulatory compliance issues. People are deeply concerned. Physicians are concerned about decisions that are made for prior auth and other services where a human hasn't been involved in the decision. And so, there's a lot of kind of hype about, this can all be done by machines. It can be theoretically at some point in the not too near future, but it's not where things are happening today. What we do see in the reality of AI is it can reduce automate. It can reduce repetitive tasks by automating, and it can lower the administrative cost of healthcare and speed processing times. That's very real. If you focus on your use case, you can really turn around massive improvements. You can use AI historical claims to improve your prior authorization logic and to reduce unnecessary denials and improve the accuracy of authorizations. And you can start using prior auth to automate labor-intensive tasks where AI can produce equal or greater accuracy and reduce the cost of some of these human-intensive activities by a substantial amount. And I put the Gartner hype cycle in the middle because right now we're sitting at the peak of inflated expectations about AI. And we've been here, this is the third time with artificial intelligence. I remember, the IBM chess game, the neural networks of 20 years ago. We've had probably 20 years of hype cycles where we reach this peak of inflated expectations only to go plunging into the trough of disillusionment. We will see the same with AI, but I think the slope of enlightenment will take us to, an area where we can really be productive with artificial intelligence. I forgot who said this, but one of the sort of great thinkers in information technology said basically, we overestimate the impact of technology in the near term, and we underestimate its impact in the long term. So, we need to look at AI with that same lens. Let's not overestimate what it can do for us today. Let's instead focus on how do we get to a tomorrow where we're getting the most out of the technology. And with that, I'll stop. And I can see we have a question. Mary Lee had to drop. Thank you, Mary Lee. But Ed, I'll turn it over to you.
All right, Danny. Well, I did write down a few questions. Well, I encourage the people attending this session to raise your hands, and I'll let you ask a question live to Denny. First of all, thank you so much for your presentation. It's really comforting to see a community come together and adopt technology. And I really like the model where you are breaking down some of the barriers of trust and people are working together. Something personal I'd like to say, Denny, I believe you joined an emerging technology call about 2.5 years ago when we were talking about Da Vinci use cases. And I really thought, man, whatever happened to Denny? He was such a cool guy. And then you get involved in Weedy, right? I mean, you started showing up to more of the calls, and you got on the board, and you volunteered to become a chair or co-chair on the education committee. I want to thank you for your presentation today, but also all the contributions you made and you continue to make for Weedy. So thank you.
Thank you. Thank
you.
You.
And encouragement to others. Gosh, if you want to get involved, be active in the work groups, ask questions, join other calls, talk to Sam and she can hook you up. Come to our conference, particularly the summer forum and the fall conference, and we can make introductions and get you involved even more. And you can be as cool as Denny, let's say. All right.
You could be as square as me. You could be as uncool as I am. How about that?
No way. So I do have some questions on your FHIR implementation, and we'll start there. Then I do want to jump over to the AI side. And again, please raise your hand if you have a question. When it comes to the PARDD, PARDD, with the proposed rule that's out there, and they recommend the Da Vinci guides, and you said it nicely, where your community is committed to following those guides. How, assuming you have a few payers that are set up in your community, how closely are they following those implementation guides? How are they working out some of the questions about how to adhere to the guides? And just kind of curious about how normalized you can make those responses.
Well, we have a lot more to learn, and we'll learn over the course of the next 2 years as we stand up this service. But what we're seeing now is that the implementation guides, the 3 implementation guides, are where our payer community wants to go. We're seeing, which I think is a terrific sort of change in the payer community, is a recognition that software applications that are proprietary are going to incur a lot of technical debt. They're not going to solve enough of their problems. They're not going to recover their costs. And what used to be sort of, take for example, a 10-year depreciation cycle, these technologies are going to exhaust themselves in half that time or a third of that time. So there's a lot of technical debt that health plans are looking at that they've incurred before with solutions that work for some of their networks and not for all of them. So we're seeing a turnaround in the health plan marketplace to, we want open, standards compliant, the use of, the US CDI, the latest or the most appropriate recent version. We want to see the Da Vinci implementation guides. We want to use FHIR. We want to use US Core, all of the standards that exist together. We haven't had that kind of, they're not talking about vendors, they're talking about standards, which is a big change. Among providers, a focus on the underlying standards and more of what I call the, don't tell me how the watch is built, just tell me that it tells me the right time. Providers are really counting on their electronic health records to provide the automation that's required here. And, EHRs are required to be FHIR enabled for patients, for patient access. That's the law of the land. And turning an API that's directed to patients into an API that's directed to health plans is not that complicated an undertaking. It's, essentially it's the same technology purposed for different applications. So we're seeing providers starting to say, okay, how do I make sure that my EHRs will accommodate this? How do I know that whether it's Epic, Cerner, Meditech, Athena Health, eClinicalWorks, there are probably a dozen major EHRs that account for 90% of the provider community. How do we know that they're going to be enabled to support this kind of standards technology? We know that a number of them are. The number of the vendors have wholeheartedly embraced FHIR. So I think we're seeing a move to standards. I think we're seeing a move to the recognition that automation comes with a huge benefit. The ROI on automation of just the CRD is extraordinary. It's the best return on investment that technology professionals have seen in 20 or 30 years. It's orders of magnitude as opposed to a 1.5 to 1 return on investment. It's more like an 8 to 1 return on investment. So we're seeing the economics starting to drive support for adoption. And we've been spending a long time as a consortium talking to our members about this, as you can see from the slides. So, sometimes you have to repeat things 7 or 8 times to be heard. And as irritating as that can be to some who heard you the first time, those who heard you the last time really appreciate it. And we're starting to build that kind of appreciation for what not only automation can do, but what a partner like us can help these organizations do together that is a lot harder to do individually. So that's what I see.
Okay, so Denny, the other communities I've seen that have adopted CRD, or at least from a payer perspective, have relied on a vendor like Olive, right, to create a portal that would be able to speak FHIR. And so it's really not integrated into the systems. And I know you and I and everybody probably on the call wants to be able to see it being automated in the EMR systems, and so that it could go straight through and integrated. Your participants, are they able to have their vendors, EMR vendors, actually participate in this, or is it more of a portal access? Okay, cool.
No, it has to be EMR. It has to be the electronic medical record. The only ones who use portals that we've designed and outlined the rationale for portal use in our RFP is there are providers out there who still do prior auths and payer communications on paper and fax. It's a lot easier. EHR is expensive. And if you're in solo practice, you really don't need an electronic health record if you're keeping good notes, but you do need a way to participate in this kind of automation economy. So, we would stand up portals for those organizations, but everything that we've envisioned for the provider side of prior auth is centered in the electronic health record. It might not be in front of the physician or the caregiver. It might be in the back office where a lot of prior authorization work is done, because physicians, many of them, don't want prior authorization alerts or notifications that prior auth isn't necessary showing up on their desktop. They want to have an unencumbered encounter with the patient.
Sure.
But they do want to know that someone in the back office knows that a prior authorization alert has just been activated, or that no prior auth is necessary, and that when they close business at the end of the day, they can see everything that's been done, and they can have a dashboard of what's been accomplished with respect to prior auth. But if we don't operate within the electronic medical record for providers, the bulk of providers, we've totally missed the boat. So we are focused, and there are a lot of points of activation. You can activate a prior authorization request when you schedule an appointment for a patient, because there may well be things that you would expect will be mentioned or proposed in that session with a patient that might require prior auth. You can do it the second the patient comes into the office. You can do it when you place an order. And at any of those events that activate a prior authorization inquiry, they don't have to be, the results of those don't have on assistant or back office desktop that's supporting the practice or the clinic, so that they can be followed through and acted upon. So that's kind of, we don't see portals being anything other than the choice of smaller providers who don't have other technology.
Sure. I'll ask a more pointed question. Do you see an EMR vendor today ready to participate in your program?
Yeah, we see several.
Really?
Yeah,
Okay.
yeah. Meditech as an example is a fully FHIR interoperable system.
Wow.
Now, technology is one thing, and making that work in the clinical setting is another. But Meditech has basically committed to FHIR interoperability in the Meditech Expanse product. And we have a lot of hospitals in Massachusetts who use Meditech, community, smaller teaching hospitals, critical access hospitals, public payer hospitals who use Meditech. We know that a number of the professional EHRs like Athena Health are committed to it, but how committed they are and what does that look like from a business model, we don't know for sure. But we do know that, information blocking provisions in ONC's rules, we know that the fact that providers are not going to pay a whole lot of money to participate in this economy, they expect it from their vendors. And vendors who come back to providers with big ticket price increases to maintain compliance with industry standards, many of these contracts with electronic health record vendors require that the vendors provide to the customer at no additional cost whatever changes to the system are necessary to comply with federal and state regulations. So, we think that, there's battles being fought with some of the EHRs who don't want to see their technology being made part of an economy as opposed to being the central piece of it. But and we think that is, again, this is kind of like reading the tea leaves, but I don't envy Mickey Tripathi or the folks at CMS who are trying to move toward a path of real interoperability that is unencumbered. But there are a number of technology vendors who are going to be pushing back on this. But it's only a matter of time, because too many customers will be left out of the benefits of this economy if their vendors don't support it, and they'll vote with their feet.
Our friend Rob Tennant has his hand up. Rob.
Hey, Rob.
First of all, let me echo Ed and thank you, Denny, not just for this and for the summer forum, but for your leadership here at WEDI. I want to go back to CRD for a second. WEDI held a panel a few years ago where we looked at the issue, what we call the belt and suspenders issue with the 270, 271. As use of the transaction increased, everybody in the industry expected the call volume for health plans to decrease, but the opposite happened. So we had automation, but the call center volume skyrocketed. And my question for CRD is, how are you able to build the trust between providers and payers so that that answer coming back is trusted? So the payer is confident that the provider has submitted the correct information, and then the provider is confident that the answer can be relied on. Because if it's a high dollar service that they were told did not require a PA, only, and then the claim is denied down the road. So how did you build that trust? Because I think that's critical.
That's a really important question, and I'm not sure we have sufficiently yet. I mean, we have a trusting community, but this is an area where you earn trust every day. You have to keep showing that what you're doing is doing what it's supposed to do, and what you've I don't want to say promised, but what you've basically said it would do. But at the same time, we're going to have to acknowledge that there is so much data noise and so much workflow noise in the system now, that with the advent of a new way of doing things, where there are going to be a lot of questions, and people are going to go, how did you get that decision, or what's the basis for that? We have in Massachusetts some recommendations that we've recommended or seconded to policymakers around post-approval denials, and how best to manage that. But I think the way to earn trust is kind of one transaction at a time, and we have a long way to go. And I don't think trust is easily lost, but it's you can get it back. And I think the way to get it back is to openly acknowledge that something didn't work as planned and that you're going to fix it, and you make the fix for that available and apparent to the end users. I mean, we're going to stub our toes a lot in this. We're going to find our participants and our community is, we're not leaving. We're not going out the door after we've sold you something and saying, oh, you've got a problem? Too bad. We're in this journey for the entire time, and we have to earn trust every single day. And we have to recognize that, people want to know. They don't expect perfection, but they expect to know. And my experience is that if we have nothing to say, we need to communicate that we have nothing to say. If something has been working well and we think it's going great, we need to communicate that it's working well. And we also need to communicate where we think things are not. But trust is precarious. And I think we have to invest in a process where we reinforce trust. We have a data governance process where we bring people together. If something doesn't work, we figure out together how to fix it, and we implement it. But I believe we'll be able to do that. But I think we're going to stub our toe, and we're going to find ourselves having to fix some eroded trust in certain areas among certain groups. And we need to do that. We need to honor, that whole idea of it's perfectly human to err, but we also need to repair and restore. So I think that's the best we can do.
I may be hallucinating, Denny, but I thought that when a response came back, and by the way, something that Rob called out, the coolest thing about the ROI with the CRD, I don't have to submit a prior auth. So it just like totally eliminates the problem.
Yeah, it's huge.
80% of the process. So it's a very easy ROI to kind of really capture. What I thought I heard was that on the CRD response, if it was, oh, you don't have to do a prior auth, you give a number in there. And I've heard that it discussed at X12 to be able to allow for that number to be submitted with the claim in the 837 to say, hey, I'm submitting this. You told me I didn't have to do a prior auth. Here's the number, and that it would be honored. And I believe that's what's they're trying to do.
That's what we're doing. We have that in our spec, is that there, and Da Vinci's been working on this too, which is that if you have a confirmation of a prior authorization approval, or that no prior auth is necessary, that confirmation number remains through the life of the transaction, and that it shows up on claims, and that you have a way to audit post-approval denials. And if you find that you have a denial when there has been a prior authorization approval, or or an indication that no prior auth is necessary, you can't simply just say, if you're a health plan, well, we changed our minds or something changed. You have to show what created that change in decision making, which raises the accountability on health plans to make sure that their CRD recommendations are solid.
Yeah.
We will have a UUID or whatever Da Vinci recommends in the way of a confirmation number that will live through the life of that particular transaction and be something that can be auditable and made part of the reporting framework that we're going to be supporting as well.
Cool. Something taking back to the previous discussion, EMR vendors are going to be seeing all the different implementations their providers are going to, all the payers their providers are going to need to communicate with. And it's more than just the actual UCDI, or sorry, UCCD, you say it wrong,
USCDI.
There you go, missed the S. Yep. Or maybe, more than just simply the schemas that are in the CRD or the DTR or the, PAS. There's, the authentication that goes with it. There's scripting that goes with it. There's timing that goes with it. And, having the providers and their vendors dealing with the differences of how the payer, is implementing things is something I would hope WEDI will be able to focus in a SNP type of an energy. You will be doing it in your community, right? And
Right.
thought about that? How do you resolve some of those differences that go beyond just the schemas?
Well, we're going to encounter a noisy information context on both the provider side and the health plan side for the next couple of years. I don't envy the folks at TEFCA. We look at interoperability two different ways. We look at what I would call lateral interoperability, which is what TEFCA does, which is, are all the providers on the same sheet? Are they all operating with the same data and have access to data about their patients who are treated elsewhere? And is there a national and scalable structure to make sure that provider data quality moves up in a consistent and systematic way? What we're interested in at MHDC is what I call kind of medial interoperability. And I use these medical terms because they're the only ones I can find. But we're interested in what happens between a payer, a provider, and a consumer. Call them a patient, call them a member. But we're focused on that kind of interoperability. And so when we look at efforts like TEFCA and efforts that the care qualities and other organizations are doing to try to normalize for all these transactions, we're wholly supportive of that. That's a huge effort, and it's going to take a lot of time. And we expect a lot of providers to struggle with the fact that their digital hygiene hasn't kept up with what automation will require. We expect the same on the health plan side.
Sure.
To bring your guidelines and to bring a process that used to be able to take 72 hours to 2 weeks to do, and suddenly say you need to render a decision in 5 minutes or 24 hours. There's going to be a lot of breakage. There are going to be a lot of people going, we thought it would work better than it did. And we're fully expecting to see that. And we're going to be looking at the next 2 years as being a way to figure out what that breakage is as quickly as possible, so that we can encourage providers and payers to focus on where the problems are most prevalent. But it's a noisy context. And the idea that electronic, if you've seen one Epic implementation, you've seen one. And even though they operate with the same version, they operate with the same sort of database structure, the way in which those data fields and components of the architecture are populated differ from organization to organization. We have multiple different coding systems. SNOMED, Loink just announced they're going to start working together with a common map between their terminologies. But we also have RX Norm and NDC. We have a number of sort of dueling for vocabularies, and that's going to create some heartburn too along the way. But this is what these processes do. They stir this stuff up that's been kind of buried due to a lack of immediacy that automation requires. and we have to be patient and work through them systematically and in a governance process that is not a smoke-filled room. It's an open exchange of recommendations among the community about how these things get fixed.
I want to ask you some quick questions and just give me 5-word answers back. Are you ready?
Okay, ready.
So a question related to how quickly are payers responding to CRD?
How quickly are we going to get to CRD?
Oh, no, sorry. How are payers responding real time, 1 day, longer, or it depends?
It's real time.
Real time, okay. And
CRD has to be 5 seconds or less. That's the Da
okay,
Vinci standard.
there you go. Cool. And then on the number of medical policies that are digitized, are your plans digitizing just a subset or of the procedures on their CRD, or are they doing a bunch of them?
I wish I had visibility into that. I don't know. I know they're doing some. I doubt few are doing all. And they're getting help to figure out, which ones are the most important that they need to do sooner than later.
Yeah, that's
There's
cool.
a lot. There's a ton in there. It's like an archaeological exit,
Yeah.
archaeological dig.
Related to AI, I think you said something really, really, really insightful, that a number of these AI vendors would do a service for themselves if they were API enabled, so that people could fit it into their workflows, into the robotic process automation. I see that a bit more on the payer side for those few vendors I've come across. I haven't necessarily seen a whole lot of that on the provider side. I've seen a few, but they seem to be much more just turnkey type solutions. But I think that was a really good call out. Denny, we are at time. You're amazing. We probably can go on and on and on. But thanks again for all your participation today. Thank you for attending the call today. And for those who are live, or for those people listening to the recording, we appreciate you listening to me. Thanks, guys.
Thank you, Denny.
Thank you for having me.
Excellent.
Sure. Thanks.
Take care, everybody.